What would you say if a parent said to you, "Can you tell my son that he needs to lose weight, doctor?" This has actually happened to me multiple times. And it's one of the hardest parts about working in pediatrics because we're sitting in the middle of a triangle: provider, parent, and teen. And everyone in that room is carrying something. The parent is carrying fear. The teen might be carrying shame. And you're carrying the responsibility of protecting that child's health. Welcome back to the Exam Room Nutrition Podcast, your guide to giving better nutrition advice. I'm your host, Colleen Sloan. I'm a PA and dietitian, and today I'm joined by Dr. Amy Beck, a clinical psychologist who works with teens and adults and is deeply involved in advocacy work around mental health and weight stigma. So this episode isn't really about how to talk about weight with kids. It's about protecting kids in a culture obsessed with body size. It's about navigating the tension between addressing the medical risk of obesity while protecting that patient's mental health. So we walk through two very different clinical scenarios. One is a child who's always been in a larger body, has normal labs, but admits to hating their body. How do you support her? And then we talk about a patient with rapid weight gain, elevated sugars, and cholesterol. So the red flags are there, and you feel like you have to say something. So how do you bring it up without sounding accusatory? What questions work with teens? And how do you get buy-in without using fear tactics? Our patients are facing stigma, bullying, and pressure, honestly, from every direction. So we must be intentional and sensitive with the words we use, because the work we do is tender. It's really vulnerable, and it's really easy to get it wrong, even when you mean well. So let's get started and learn how to do this better. Dr. Beck, I'm so excited that we connected through a mutual contact in this space, and I'm really excited to chat with you today because this is a topic near and dear to my heart. So thanks so much for the gift of your time, and welcome to the show.
Likewise, my pleasure. Thank you for inviting me. I'm happy to be here.
All right, well, I want to start with some common mistakes that well-meaning or well-intentioned clinicians can make when we're talking about diet or food or weight, specifically with kids and teens. What are you seeing are some common things that you think are quite harmful to our children?
Yeah, great question. So what I have seen is focus on numbers on the scale, such as weight, numbers of like carbs that you should be eating or not eating without focusing on health. And part of, I think, why that happens is one, some ignorance, but also two, there's a lot of time constraint working in primary care, working in a busy clinic. And so it sort of tends to have a sense of getting just straight to like, here's what you need to know kind of thing. But that often doesn't feel good when you're living in a larger body and dealing with a lot of the ramifications of that out in the real world, stigma, discrimination, et cetera, which children absolutely do experience. And so focusing on health and then healthy behaviors is really the type of language and focus that we want to have without getting really caught up in numbers that kids aren't going to pay attention to anyway. No kid counts their carbs, nor should they.
Yeah. Well, I'm really excited to dig into this because I fully agree with you in that, but I get a lot of pushback from some of my clinician friends and who say, but I need to talk about their weight, right? Like they kind of feel this responsibility to bring up their weight, especially if it's a child with obesity, severe obesity maybe, and we do notice maybe some consequences, negative health consequences. So how do we navigate that? Because it's that fine line, that balance between weight may become a problem or may currently become a problem, but we don't want to stigmatize or cause any issues down the road. How do we do that?
Yeah, great question. Well, and a lot of it's going to depend on the developmental age of the child, right? You can have very different conversations with a 5-year-old than you can have with a 15-year-old and older. Really just, again, everything you want your true north to think about health and leading into it from the perspective of health. And you can ask, like, how does your body feel? And talking and asking about behaviors without ever having to use the W word. You don't have to use the word weight even to talk about weight, right? Again, focusing on, tell me about your healthy habits, like how many fruits and vegetables are you eating? What kind of exercise are you getting? And really starting to back into those conversations from that pathway, because the reality is that's that's what you should be talking about in intervention anyway, regardless of why you are speaking on it.
Yeah. And we're going to get into some more detail on exactly the language that you guys should be using. But I would love to hear from your lens and your side of the exam room. Like, how have some of these negative weight dominant conversations affected some of your patients?
I have, aside from hearing a number of stories of folks sharing, and folks being children themselves, sharing negative experiences that they've had in healthcare with providers and systems, I have apologized on behalf of healthcare a number of times to different children who I've worked with. But I watched it happen one day. So I was in a different clinic. I worked in a weight management clinic. I was not in that clinic. I was seeing a patient who was a weight management patient, but I was trying to coordinate. She was there for some, like an infusion or something, I believe. So I went to go talk to her. She was very hesitant to speak about her weight, really sensitive about the topic. I think she was definitely a teenager. I don't remember the specific age. And we were really having a good conversation. She was warming up. I was developing rapport, and we were starting to move into a little bit of a harder conversation. And then the physician came in and was coming in, doing what needed to be done, and started having a conversation about counting carbs. And I watched this child's face fall immediately. And then the physician left, and I was still there. And I tried to pick up where the conversation had left, and that child was completely shut down, gone. I could not get her back. The damage had been done. And I never saw her again. I don't think she ever came back to a weight management appointment, even though that provider was not even in our clinic, but it was just that experience. I watched it in real time, that child being harmed.
Do you know the reason I started this podcast is actually because of a situation very similar to that? But I was in clinic one day and it was one of my first patients of the day. And, you look on the folder, you see why they're there. He was there for like a rash. So I'm like, okay, awesome. Like quick, easy visit. But I go in and this boy who was 9 was crying, which in a pediatric office isn't unusual because they think they're always getting shots and they hear other kids like screaming for their lives. But like it was a sick visit. He kind of knew he wasn't there for a checkup. So I just casually had said, "Hey, buddy, what's wrong? Why are you crying?" And the mom spoke for him. And she said, well, the last time he was here, which was about 6 months ago at his checkup, the doctor said that he needs to lose weight. Or if not, he's going to have to take shots in his belly because he's going to get diabetes. And today he stepped on the scale and he gained 3 pounds. And he's really upset that he let the doctor down. And now he's really scared of what's going to happen. My heart just sank in that moment because how inaccurate, right? That fear-based messaging actually affected this child so much. The mom, we through a deeper conversation, she told me that he had been restricting his meals. They were of Asian descent and he was no longer consuming their culturally diverse foods. He also was weighing himself multiple times a day. And so one simple comment led to such a distorted eating pattern and negative thought about himself and his body, when in actuality, he was supposed to gain 3 pounds. He was prepubescent, right? Like that part of biology was normally happening. And unfortunately, it was framed in such a negative way. And I'm sure, well, we could just share stories back and forth all day long. But psychologically, can you explain like how or maybe why these little flippant comments that we say actually do trigger shame and that restriction and that disordered eating habit? Like what is going on in the child's brain that's causing this to happen?
So, disordered eating is so complicated, and just like obesity is very genetically driven. So there's not kind of one thing that's happening, but when there is a genetic predisposition, right, there is an increased likelihood that these kinds of comments may result in a shift in behaviors. If someone has a predisposition to an eating disorder, there is an increased likelihood that even when you do everything right, that this can be triggered, right? Genetics are incredibly strong. However, the way to think about it is utilizing universal precautions with our language with everyone to reduce harm as much as possible, right? It's trauma informed. It's the same reason we wear gloves when handling anyone's fluids, right? Because we don't know what is going on. And so it's universal precautions, protections for everyone. So thinking about the words that are being used, never using fear-based techniques with anyone, right? Whether there's a genetic predisposition to disordered eating or not, right? We know from data that that approach is not going to be helpful. And especially for a young child, it can be scary.
All right, let's unpack these two different age groups of kids because when we talk pediatrics, like you had mentioned earlier, talking to a 5-year-old is drastically different in how you might talk to a 16-year-old. So, give us some examples, some language that is appropriate for a 5-year-old, and then give us some examples of how you would address a conversation with a teenager.
Yeah. So, regardless of age, you still want to be focused on health and behaviors. With a child, a younger child, like a 5-year-old, it's going to be a lot of conversation with the parent. But of course, you want the kids to be able to be there and understand. And so you're going to be talking in simple language about the basic things that you want them to be doing, like exercise. But for a 5-year-old, that's playing, right? What kinds of things do you like to do? How do you like to play? And who do you like to play with? And finding that buy in from them with the joy of a lot of these things. With an older child, once you start into tween and teens, especially, the developmental stage is for autonomy. And so teenagers want nothing more than to be given their own power and decision making. And so you still are talking to their parents, but you are directing a lot of that conversation to them because they're making choices that parents, right, when they can drive, when they can go to wherever and get food themselves, you want them to have their own reasons and speak to them and have their rationale into why they want to make these decisions for themselves.
You mentioned the word buy in, and this is something that can be very difficult to do, right? I know we should be consuming, 5 servings of fruits and vegetables, but especially when it comes to veggies, the default for a lot of clinicians is to say, oh, but don't you know how good they are for you, right? We think like telling a kid, like, this is good for you is automatically going to make them be like, oh, great. I'm going to eat some broccoli today because it's good for me. So, how do we frame our conversations around those types of foods without making it fear-based and getting buy-in from the patient?
Yeah. So you can tell someone that it's good for them, but most people already know that.
Right.
And, find me an adult who's like, oh, yeah, I'm going to totally do this right now because it's good for me and have that be a consistent daily basis thing. There are some adults like that, but it's not going to be most of us, I don't think. And so you want to get buy in, especially from a young child, in as many different ways as possible. Younger children love to help pick out things from the grocery store. They want to help their parents prepare them. So, getting their interest in a way that's hands on, that's creative, that's interesting to them, that's going to go a lot farther than being like, it's good for you, so you should eat it kind of thing. Also, being aware that it takes multiple trials to start to change your taste towards something, and you might like something prepared in one way as opposed to another. So, it's also about working with a parent to have that openness to continuing to try to offer in a number of ways and having guidelines at the dinner table, right? Like you don't have to like it, you don't have to eat the whole thing, but everyone does have to have one no thank you bite just to try it. And being able to keep putting things on plates and over time, right? This exposure can really be part of the process of getting kids to be more open to foods that perhaps there's not a natural inclination towards, which is often the case with many vegetables.
Yeah. All right, let's talk a little bit about growth because in my field, in general pediatrics, growth charts are kind of everything. We look at this at every well child check, but often it can be in a parent's mind a measure of success, and a child can think that they're doing good, quote, if they're on a certain percentile, and can feel shame if they've really gone up, 30, 40 pounds, and the line is like in a drastic vertical motion. And so I would love to hear, how do you talk about or even do you show a growth curve directly to a child? And maybe when might it not be appropriate?
So in the clinic where I worked, that was multidisciplinary for pediatric weight management, we did not let any child see their weight, period. Not even growth curves. Like the scale was covered in terms of the number. Because again, that's not the conversation. The conversation is health and behaviors. Um, However, there have been instances when we did show a child their growth curve, and that was only for teenagers and only if there was healthy, sustained weight loss over time, where it could be visualized on the curve in a way that could be meaningfully reinforcing. That was very rare.
Yeah. I will always ask the child, typically 5 and up, 6 and up, depending on their development, are you comfortable if we talk about your growth today? Or can we talk a little bit about the foods that you're eating? How do you feel about that type of language, talking about permission before
Yes.
even going there? Thoughts on that?
Yes. Yes. So that is a strategy from motivational interviewing called elicit, provide, elicit. And that works for all ages, even little kids, right? Asking, it's consent essentially before I throw information on you that you might not be ready to hear for whatever reason, which is valid, right? Um, Asking, getting that consent, and then providing the information. Absolutely. Great strategy.
Yeah. I will tell you, I have had multiple patients, kids, I had a 12-year-old say, no, I'm not comfortable with that. I said, okay, you know what? That's fine. When you are, and if you're ready, I'm here to discuss it, but let's talk about something else, right?
Absolutely. I would say a question you can use in that situation is, would you be willing to tell me why you're not comfortable with it? You don't have to, but I would appreciate it. And I'm just a little bit curious.
Okay. The other pushback I get when I ask permission and the child says no, that is from the parent, especially if it's maybe something about growth chart and maybe the child is 16, but for whatever reason, the child said no. The mom usually is like, no, but I want to see it. So I will then say, well, I want to respect your daughter's choice to not see it. So once she goes to the lab or once she's doing something else, like we can have that conversation. How would you approach that with the parent if they're the one that's pushing for this conversation?
Yeah. So I like the example that you gave because my recommendation, especially for teens, if there's discord, is to separate them and have individual conversations so you can hear both valid perspectives, but not have someone being overridden, especially the child. The child is probably used to being overridden, and that's not something that you want to reinforce.
I love that message so much because I see it all the time. So help me navigate these conversations because having the parent child relationship in the room can be really, really tough and in general pediatrics.
Yes. I having done pediatrics and adults, I will say pretty definitively pediatrics is harder.
Yeah.
Because of what you just said, having to navigate both. I think that's a great opportunity for a conversation with a parent to ask why it is such a concern. My experience, not universal, but frequently is that parents have their own history with weight. It is a lot of fear from the parent of like their child being bullied or something negative happening to their child, or weight stigma is very real. And so those are legitimate concerns. However, what can be the case is that concern that is coming from a good place then becomes more harmful than whatever it is that the parent is afraid might happen to their child.
Yep. I I have seen that also not just fear with like the child maybe being bullied or stigmatized, but also fear of a family history happening, like a grandparent who was just diagnosed with diabetes, or maybe that parent themselves has diabetes. Somebody had a heart attack, right? They almost had like a health realization, and now they're putting that fear on the child. The opposite end, and I would love your perspective on this, is the mom, which is typically a millennial, older millennial, grew up in the diet culture and on her own weight journey that she's putting that now on the child. So, how do we validate mom's concerns and at the same time protect the child's mental health there?
Yeah. So true north is always that most of the time parents are there for the best interest of their child. And in their own fear that we're talking about are often not really thinking about the unintended consequence of the harm that is being done to their child by the way they're enacting their fear, right? It is, again, meant to be loving, but with a focus on that, they're not always saying that, hey, this is hurting your kid. So it's validating their concern, validating why they're concerned, and then bringing it back to you love your kid, right? You want the best for your child. And let's think about how we can work with all of this in a way that your kid is clearly not handling this well, right? Like you told me this was the biggest fight you've been having at home. It's the first thing you came in talking about. I watched your kid. And again, this is a conversation with the parent. The kid's not in the room at this time. I watched your kid really sort of slump over and look defeated when you said this. This conversation is not going well. Let's talk about ways to navigate it differently, right? Because this is other harm that is not helpful for what you're trying to do. So it's validate, but also redirect by pointing out, hey, the way that you're doing it isn't working and you're causing unintended harm.
Yeah, that's so good. All right, I want to talk about two different patients now. One is, we'll start with the child who is in a larger body has always been in a larger body, and I actually have no concerns, right? Maybe he is 12 or 13. We've already done some baseline labs based on the screening recommendations, which is typically to do some cholesterol screening between 9 and 12. Maybe we've done an A1C, so we've ruled out diabetes. Their blood pressure is fine. Like, medically, they're okay. I would say they're fine, but their weight has just always maybe been 95th percentile, 98th percentile. So they are in a larger body. And this child does not like their body size. How do I navigate that? How do I help them in my short amount of time kind of learn to accept and maybe love? I think that's a difficult, thing to do in a
Yeah.
short time, but what
Yeah.
words can I use to help them kind of through this body acceptance?
Yeah. So one, that's going to be a referral. That kid needs to see a mental health professional because body image is more than what you're going to be able to accomplish in a brief amount of time. That said, ask the kid what's going on. You seem like this is really bothering you. What is going on that, would be helpful for me to know about why this is so hard, right? A lot of times kids don't tell their parents about bullying because they don't want their parents to, go up into the school and do all the things, or they feel like it's not going to help. But you can get some of that information out of them and finding out sort of what that missing link might be.
Yeah. It's so hard, because I've such a joy and compassion for my kids, and it just breaks my heart to see them not seeing themselves as I see them, right? As these beautiful creatures who are capable of so many things. And so I always go back to just reminding them that you're a cool kid, you're smart, you're funny, and your body size has nothing to do with your worth or your value. Is that something that would be appropriate to mention, during a
Oh,
checkup?
absolutely. Yeah. One of the things that, and this is more for teenagers, but there is actually research looking at this concept of what's called radical acceptance for specifically Black adolescent girls with binge eating disorder. But you can generalize it beyond that because I've seen it be so successful doing this, is talking to kids about, right? Like, we can't control what other people are doing or saying, right? Kids can be mean. We look around in society today and there's a lot of meanness that's just global. And we can't control that. And the benefit of this concept of radical acceptance is saying, you know what? I accept what is happening. It doesn't mean that I condone it. It doesn't mean that I like it, but I accept it. And the power in that is that so much distress is energy wasted on wishing things were different. But when you say it is what it is and I accept this, that frees up that wasted energy and it allows you to then focus that energy on, okay, what can I do in the situation? I can't change other people's behavior, but what can I do, right, to cope or function or exist in this space in a way that doesn't hurt me as much? And that conversation, again, especially with teenagers, is incredibly powerful. And so giving that knowledge, as well as being that person who will always be in that kid's corner and always be supportive of them, is powerful.
Yeah, I think that's the beautiful job and responsibility if you are a pediatric care provider that we have to always ensure that this tiny office room that we are in, this place is safe. I will never
Yep.
judge you. I will never
Yep.
speak down on you. I will never shame you, no matter what your body size and what you're struggling with. It's like the same thing that we do if a 15-year-old comes in and she's got an STD. I'm not there to judge you. I am there to treat you and to get you better. And it's the
Yeah.
same that we should do, I think, with body size. All right, let's talk about the other child who maybe has morbid obesity and or has gained 30, 40 pounds in the last year. So an excessive amount of weight gain that may be concerning. Maybe we already do have some elevated sugars, we've got some elevated cholesterol, so we have some issues that my red flags are going off as a provider, and I do feel the need to intervene. How do I adjust that conversation? Because at the top of the hour, you had said we still don't want to mention weight, but weight feels like the elephant in the room. So, what do we say in clinic at that moment to kind of start initiating some form of intervention?
Well, so I would go back to the reason why the appointment was made, right? What is the kid there with? If it's something that is weight related, that's a great way to back into it. I had the sort of luxury being in a weight specific clinic so that everyone knew that's what they were there to talk about. But kids know when they've gained weight, right? Especially a significant amount. You still don't even really have to talk about weight because if you're focusing on the health and behaviors, you can still avoid the W word getting from that like asthma or, hypertension or whatever kind of thing. If there's no complications and it's solely looking at the rapid weight gain, you'll probably use the W word then, but it's not going to be a surprise to the kid. And just like, hey, things are probably going different for you this year than before. What's your year been like, right? Tell me about what has changed, maybe what's been stressful for you. Have any of your behaviors changed? Has your sleep, like, just trying to open end it to see what you get. And if you're still not getting anywhere, you can then guide into the, hey, I'm asking you some of these questions because I've noticed, and I'm sure you've noticed too, your clothes might be fitting a little bit tighter right now. I notice, the weight has gone up a little bit on the scale. You're not in trouble. I'm not mad at you. But what's going on? This is different than how it was for you before. Can we talk about it? Would that be okay with you? Right. So what you're trying not to do is coming in accusatory because that is how it's going to feel a lot of the time. So taking explicit care to not do that.
I love that approach because often it's necessary. It's kind of that important balance, that tension that we sit in of like, if we say nothing and unfortunately down the road, if the child does develop type 2 diabetes, high cholesterol, some kind of concern, they might look back on us and say, hey, why didn't you say anything? Why didn't you tell me? Why didn't you guide me? But at the same time, again, we're not trying to accuse them or judge them or blame them for anything that might be happening because it could just be solely genetics, biology, or maybe there's an access issue. And so that's why they've gained weight the last 6 months, right? We don't know unless we ask.
This will always be a sensitive, somewhat tricky dance because of the culture and society that we live in. But again, at least from my perspective and from what the data talks about, the true north is always working to minimize bias. And that is a self-check. You have to really be thinking about who you are and what your perspectives are, what your biases are, because newsflash, as humans, we all have them. And healthcare providers are humans. So healthcare providers have biases. And so what are they? How are they showing up? Why are you asking this question? And do a lot of that self-reflection work. Because if there is a strong bias against individuals living in larger bodies, it's going to show up in how you interact with folks if it goes unchecked. All of that said, recognizing that sometimes, even with all of these universal precautions and self-checks and all of this in place, there can still be harm, right? Miscommunication happens. None of us is perfect. It's hard to be a provider. You're having a bad day someday, and sometimes stuff just doesn't come across the way that you might want it to. Being open about that, and, we talked about how kids so often don't feel validated. Kids also rarely get apologized to. And so saying, you know what, hey, I'm sorry. Like I said that in a way that wasn't nice. You know what? I really screwed up. I'm sorry. Can we start over? Because I really want to help you. And I didn't do a good job of that before. So can you forgive me? And can we start over and try again? Like that is huge.
That's huge for an adult to hear even, like,
Correct.
I mean, you're right. Apologies are super rare now, either, especially to kids, but even adult to adult,
Yes.
I've never heard a clinician apologize to me, maybe for
Yeah.
running late, but not really
Yeah.
owning like, ooh, that came off wrong. I didn't mean for it like that way. Let's start over. I really, really like that. And I think that shows that we're human and that you are trying
Correct.
your best and we're all learning how to
Correct.
navigate this.
Correct. Yes.
I really like too, you kind of answered my question in how you were guiding us in the conversation here with that child. Because I often will ask questions like, hey, how's it going for you in school? And they're teenagers. So you get like, fine, good answers. And I'm digging for more. So sometimes you're like stuck, like, ooh, that didn't lead me anywhere. So you as the provider do need to kind of have a set of questions, kind of those leading questions to help you in that moment, because probably 95% of the time those teens are not going to be like, oh, well, you know what? I am really struggling internally with the
Yeah.
size of my body, right? Like they're
Yeah.
probably not
Yeah.
going to open up unless you already have that relationship with them. And so I love how you guided that conversation. So how else can we get those teens who really just seem closed off to open up to us?
Yeah. Well, and self-disclosure, teens are my favorite.
Awesome.
So, um, one of the things that one of my tried and trues is always for a kid for a teenager explicitly who's not really giving me much is, what I hear from other kids is they say X, Y, and Z. You know, you can tell me I'm wrong because again, teenagers want autonomy. So me telling them that they can tell me that I'm completely wrong, hugely powerful. And so, this is what I'm hearing from other kids. My guess is that might be the same for you, or, I could be wrong. You tell me here's sort of my hypothesis or what I hear from other people to give them something. Because what that does is one, it gives them the power to say yes or no, and they can tell the doctor if they're wrong, which they love.
Hmm.
But it also validates that they're not alone, right? That you are comfortable with whatever it is. And so there's not an embarrassment there. Like they're not a weirdo. They're not a one off. Like, hey, this is a more common thing that you're aware of. And hey, we can have that conversation because I've had that conversation with other kids kind of thing.
Oh, that's huge. And I never really thought about it, but it makes sense. We're seeing Gen Z is like the loneliest generation that really has ever been. And I really love, in a way, letting them know, like, hey, like, I have other kids that they're kind of in the same camp as you, like we can work on this together. You're not like some alien from outer space that we've never had to deal with this before.
Yeah. Yeah.
I want to close out our conversation. You mentioned one example where you think a referral to mental health is important, but what are some other signs that we should be looking for as a provider that might say, this is out of my wheelhouse, or this child needs more support than I can provide?
So I would say best practice, generally speaking, is everyone can benefit from mental health services because weight loss is hard and chronic and long term. Really, when you want to push for mental health intervention, anytime you're seeing depression, anxiety, or ADHD, which is prevalent in about 1/3 of individuals dealing with weight challenges. So that goes undiagnosed a lot and is often a barrier to moving forward. If you're seeing kids with signs of disordered eating, binge, restriction, all of those pieces. And then one thing circling back to the depression. So we know that kids with more severe obesity, particularly adolescents, have an increased risk of suicidal ideation. Not increased attempts, fortunately, but ideation is increased. And I saw that all of the time. That data was replicated in the clinic where I worked, and I worked in pediatric obesity in multiple clinics across the country, and I saw that everywhere. And so, anytime there's really any sort of mood, anything, one, you want to make sure that you're screening for suicide, and that is obviously going to be a referral.
It's such deep and difficult work that you do. And I am just so grateful that there are providers like you, Dr. Beck, who are walking alongside these kiddos and showing them that providers can be loving and supportive, and we can, help create a healthy future for you without stigmatizing them or judging them. So I just want to say thank you for the work that you're doing and for being the voice in this field. I'm really grateful for you.
Thank you. I appreciate that. And likewise, I really appreciate that you are having this forum, that you are focused on this because it takes a village. This is a hard disease. And there's so many kids that need all of our support. So right back at you.
We got to do it together. All
Yes.
right. Well, if people want to connect with you online or just learn more about you, where would we direct them to?
Ooh, great question. So I am currently working with health psychology partners, and that is the website, healthpsychologypartners.com. And so I see both adults and children in that practice. I also can be found on my LinkedIn page, which you go to LinkedIn and you search for my name, it'll pop up there. And then I am currently working on my website, that is arbphd.com.
Awesome. I will link to all of that down below in the show notes. She's a great resource to keep on your Rolodex. And Dr. Beck, thank you so much again for the gift of your time. I appreciate you being here.
Thank you again. It was lovely.